is an increasingly prominent part of the work that you do in primary care, which is managing ADHD in adults in your practice. My name's Nick Cates. I'm a psychiatrist. I apologize. I'm with the Department of Psychiatry at McMaster University. I also have an appointment in the Department of Family Medicine. But I would say almost everything I've learned about ADHD has come from my clinical work in primary care over the last 35 years, and also watching the transition of our son as a parent from a child with ADHD to today where he's a captain with a major Canadian airline, and seeing all the steps along that journey. And that's part of what I want to go over in today's presentation. The disclosures, no financial support either for me or for this presentation. The only thing I do have to declare is my lifelong devotion to the English football team, Arsenal. So what I'd like to do today is go over the prevalence and key symptoms of ADHD in adults, the consequences and comorbidities, and then focus on detection and assessment and management, which I've divided up into kind of pills. So looking at medication, the options, and the way we can use it, and the skills that go along with it. Because although medication is the core of the treatment, there are many other things that we need to do to assist individuals who are living with ADHD. And I should also say, by way of disclaimer, I'm someone who should never be left alone in a hotel room overnight with a slide deck without a chaperone. So there will be a few small adjustments to some of the slides from what's actually in the slide deck you received. So it's a very common disorder. We know it's 6 to 9% of all children. 40 to 60% continue to have problems as adults. So it's a condition that you grow out of as you get older. But it does mean that maybe 4 to 5% of all adults are dealing with symptoms of ADHD. Doesn't necessarily mean they need treatment, but they have residual symptoms, which would make it one of the most common psychiatric disorders. It means in an average practice, you probably have about 60 adults. It's democratic in terms of socioeconomic classes. Male to female ratio is about 2 to 1. The prevalence changes with age, so it is a maturation process, and that goes all the way through into your 60s or 70s. But less than 10% of those with ADHD are identified or treated. These are just a snapshot of individuals who have self-declared, with one exception, that they have ADHD. And these are just some historical figures. And again, when you look at that list, there's some of the most creative minds maybe who've ever been, who are part of that list. So, as I say, it's common. For those of you who are baseball fans, this was 2019, 10% of all Major League Baseball players had permission from Major League Baseball to use a stimulant. So they'd been diagnosed, and the commonest stimulant they used by far was Adderall. So the prevalence, more or less everywhere you look, is high. But what exactly is ADHD? We tend to think of it as delayed maturity in 3 domains: attention, hyperactivity, and impulsivity. And those really have formed the basis of our diagnostic approaches. This is from DSM-5. And again, it divides the criteria up into inattention, ADD, impulse and hyperactivity, ADHD, or you can have both. And from the list of symptoms that I'll show you in a moment, you need to have 5 to make a diagnosis. It also needs to have persisted for more than 6 months, and it needs to be persistent and maladaptive. And it needs to happen in at least 2 domains of an individual's life. So the consequences can't be just in the workplace or in their family. If that's the case, it's probably not ADHD. And one of the changes in DSM-5 was to shift the age of onset from 7 to 12. So now you can present with symptoms and be diagnosed with ADHD from 0 up to the age of 12, whereas before we used to say it was just up to 7. These are the attention tasks, and again, I won't go through each of them, but as you read through it, they're sort of fairly basic tasks that you would expect with someone who's dealing with inattention. And these also can form the basis for questions that you may want to ask in some kind of screening assessment. It includes poor time management and difficulty in persevering or completing tasks. So a lot of attentional issues. The hyperactivity or impulsivity symptoms, again, slightly different in adults than they are in children. It may reflect in their choice of jobs, some of the activities that they take part in or avoid because of having to sit still or repetitive work. You'll also find that they often have a history of multiple job switches. It's difficult to stay in the workplace, and often they leave not just because of the ADHD, but because they get into an argument with an employer and they can't modulate their temper. Intolerant, impulsive, snap decisions. And the last point is an important one. And although it just is one of the criteria, losing temper easily, angers quickly, someone called Paul Wender, works in Utah, about 20 years ago, came up with a slightly different set of criteria. And although he included at the top all the ones that go with traditional diagnosis, attention, hyperactivity, disorganization, impulsivity, he also identified 3 other areas: temper, affective lability, and emotional reactivity. And these are an important component of the way ADHD can present and its contribution to the problems an individual faces. So in some ways, ADHD is actually delayed maturation in 4 domains: attention, hyperactivity, impulsivity, but also emotional regulation. And again, that can also give you some clues about when maybe to pursue a further assessment. The severity of symptoms present along a spectrum. As I mentioned before, they improve with age, so it is a maturational process related to dopamine and noradrenaline transition. But also, as we get older, we learn new skills and develop maybe some compensatory mechanisms to deal with the symptoms, particularly if they're at the minor end of the spectrum. And that may be another reason why people don't present, because it's not that maladaptive. The presence doesn't always require treatment, and I think treatment decisions need to be based upon the extent to which it interferes with daily activities. But it's also, I think, again, important to think about the concepts of readiness for change, because if you're to treat someone successfully, they first have to buy into the fact that they have a diagnosis. And pushing treatment before they've reached that point, I think, is likely to lead to much less successful outcomes. So when you're working with someone, your first task may be just to explain what's going on, ask if they have any questions, ask if what you're describing seems to fit with them. The course, as I say, it begins in childhood, and childhood problems move into adult problems, whether they be more significant alcohol abuse, relationship issues, job, school performance, and then trouble parenting. Adults are more likely to act in than act out. So they're more likely to kind of internalize some of the things that are happening to them than children, who are more likely to act them out. And some individuals will present when the structure of home or school is removed. The hyperactivity and the impulsivity tend to decrease over time. but the attention problems usually remain fairly constant. And that obviously can be a challenge, particularly as someone moves into higher education. And unfortunately, the childhood symptoms become adult symptoms that have much more significant consequences. So school failure leads to job failure or unemployment, underemployment, motor vehicle accidents, drug dependence, criminality, unwanted pregnancy, sexually transmitted diseases, but also the sense of hopelessness, frustration, or giving up. So again, untreated ADHD has many significant consequences. This is one that I think is so important, particularly if you're seeing children as well as adults, and that's the impact that the presence of ADHD has on your self-esteem. And it begins, you have poor social skills, a little bit of odd behaviors, your mood may be a little bit erratic, you become isolated, maybe bullied, and that leads to anxiety, low self-esteem, and a lack of confidence. So in addition to the cognitive or other deficits associated with ADHD, many adults with this condition are also dealing with anxiety or lack of confidence, which can become as disabling, but in a different way than the symptoms of ADHD itself. There are a number of domains of impairment, and these are some of the other costs of ADHD. As I say, it affects every aspect of a person's life potentially. So it increases the likelihood that you're going to be involved in a motor vehicle accident. It increases directly your medical costs, again, often from accidents, increased likelihood of being unemployed, significant increases in incarceration rates. No one knows exactly how many people within our penal system do have ADHD, but some estimates have put it as high as 40 to 50%. Increased problems with sexual health and increased medical costs to the system. The etiology of ADHD, this is just one proposed model that the problem arises in the prefrontal cortex, which is the area of working memory, self-regulation of affect and arousal, and behavioral analysis, how we stop and think before we act. So these are some of the functions: self-regulation, future-directed activity, control of emotions, planning and organizing, that can be affected by ADHD and a maturation problem in the prefrontal cortex. It tends to affect the dopaminergic and noradrenergic pathways. And for reasons that I don't think we completely understand, there does seem to be a link between lack of REM sleep in pregnant mums and the likelihood of ADHD developing in their children. In terms of comorbidities, 60% of adults in your practice, 20% of their mothers and 25 to 30% of their fathers will have ADHD. 20 to 30% will have a depressive disorder. So these are people with ADHD will have a depressive disorder. 7% will also have bipolar affective disorder, and 50% will have an anxiety disorder. But I think it's helpful to look at it the other way round, because you're more likely to see someone who has a major psychiatric diagnosis and then start looking for ADHD. So while the prevalence in major depression is only 9%, if you have an adult with bipolar disorder, there's a 20+% likelihood that they're going to have ADHD as well. And that's one of the reasons why ADHD can be difficult to diagnose, because the symptoms of ADHD, and particularly cyclothymia, the milder form of bipolar disorder, are often very similar and overlap. 10% of people with anxiety disorders will have ADHD. And this is important as well. If you're looking at people who you think have chronic dysthymia, pervasive developmental disorder, not only think about the presence of ADHD, but often the use of a stimulant can actually be helpful as an adjunct to treat people who do have chronic dysthymia, whether you've diagnosed ADHD or not. 25% will have a comorbid substance use disorder. The lifetime risk of developing a substance use disorder is twice as much if you have ADHD. 75% will have a sleep problem, and that's often delayed sleep phase syndrome. They have difficulty getting to sleep, and their natural waking time is always a bit later. And 20% will have symptoms consistent with autism spectrum disorder. And think about autism spectrum along a spectrum. These are usually at the mild end, and they're often things like increased sensitivity to stimuli, not liking labels or particular kinds of cloths against their body. But a significant percentage of adults with ASD will also have ADHD. How does it present in primary care? One way is it's self-diagnosed. Either the person says they've been thinking about it for a while, or their child or parent receives a diagnosis. And there are a number of times I've been in an interview with a child in primary care, and it's been the parent who actually has more significant difficulties with restlessness or tics or focusing on the interview. Often it's a friend or relative who suggests it or suggested they complete an online survey. Sometimes there's a celebrity ripple effect. So if you notice, Britney Spears was in the first picture. And again, when a celebrity starts talking about their own struggles with ADHD, which is great, it makes it easier for people to kind of self-diagnose. Or you'll meet with someone, maybe a new patient, who's had a previous diagnosis as a child. These are three different ways in which people I've seen in primary care have been referred. Bob was self-referred. He was concerned about his mood in response to life stresses, but he also had an inconsistent work and relationship history. So he met the criteria for both attention deficit disorder and for depression using the PHQ-9. He decided that he wanted to start with an antidepressant. I chose bupropion because it is the antidepressant that is meant to be the most effective in treating ADHD. And even though he improved on the antidepressant, he still met the criteria for ADD a year later, and he asked to start on dextroamphetamine. So again, when you see someone with depression and ADHD, leave it with them as to which is the most difficult problem, which is the one they want to start addressing first. Jane was referred to me for an assessment of bipolar affective disorder. The mood swings she was describing were more consistent with cyclothymia. They weren't as severe, they weren't as prolonged. But she also had a history of inattention, distractibility, academic underachievement. 2 diagnoses. We started lithium, again at her request, but she was reluctant to start a stimulant. So again, I think it would take more time before she was ready to begin on a stimulant. And this was Heather, took an online screen, came to her family physician requesting medication, met diagnostic criteria, and did well on a long-acting methylphenidate derivative. So in terms of detection, it's not always easy to detect. Say it's a diagnosis that's based on behaviors. Symptoms present along a spectrum, they overlap with other conditions, it may be comorbid, and the previous history is often undocumented. And you will find people in their 50s, 60s, even sometimes 70s, who clearly are presenting for the first time with ADHD, but they have no real school records or documentation from 40, 50, 60 years ago. But don't dismiss it just because someone is older. And as I mentioned before, it can be a vogue diagnosis, so false positives can often present in that way as well. A few clues to the presentation. These are some of the flags from the history that someone will be telling you about concentration, organization problems, their difficulties at work. Always a good question to ask them, do you feel you're underachieved, whether that be at school or whether that be as an adult? But also someone with relationship instability, a family history, or someone who's presenting with poor self-esteem. None of these are diagnostic or pathognomonic, but they're all clues to help you zero in on a possible diagnosis. These are some other: mood and anxiety with a poor response to treatment, drug abuse or dependency, job changes, driving infractions, accidents, and always ask about their performance as a child. And the last point is interesting as well, that kids with ADHD may do better in the visual subjects and worse in subjects like math and science. In your office, they may be forgetful, they may miss appointments or arrive late, lose prescriptions, not follow through with plans, may be hyper talkative or fidgety, or may have emotional storms triggered by life events. Again, these are all clues to help you to move towards a possible diagnosis. So in your assessment, if you suspect, these are some of the things you want to zero in on a little bit more closely: symptoms and the course and time frame. The course is an unchanging one. It's not, I had 3 good years when I was at university and then it started again. It will always be there. Other mental health issues or diagnoses, relationships, and then go back. Any family history, legal history, or any issues around school or work performance. And it's always so important to get history from another family member, whether it be a parent, a child, a partner, or a significant other relationship. And what you're really doing is following a kind of 3-step process. The first is to go back and look at some of the fixed points that might suggest ADHD once you have a higher index of suspicion. Then look at some of the current functioning and all of the kinds of symptoms in the DSM-5 or some of the other things that I've been talking about. And then maybe for confirmation, complete the ASRF and a diagnostic interview. Screening interviews aren't diagnostic in and of themselves. They're self-reports. They also point out particular areas for intervention. So as someone fills in a screen, there are 3 that are commonly used. That one on the screen is the Weiss Functional Impairment Scale, but the one I use the most is the ASRS, the Adult Self-Rating Report Scale. And as you look at the different criteria, each of them raises, an individual is asked to rate how often this occurs, from never to very often. And you'll invariably find that there are some areas that are never, and there's some areas that are very often. And the very often are the ones maybe that you want to look at in your management plan. But, let me just pop back for a moment. But if you look at the scale, I've separated out the top 6 items because those are the ones that help you elicit a diagnosis. And each of them has shaded boxes on the form. The first 3 items, sometimes, often, and very often are shaded. The last 3 items, often, very often. Inattention, hyperactivity, or impulsivity. If someone ticks 4 boxes or more in the shaded area, you have a fairly good idea that they're likely to have ADHD. And that can probably inform your next step. And as I say, family members can bring a different perspective. My family's all grown up now. except for my husband, of course. But it can be so important to get that information, and also to engage a family member as a partner or a coach. These are 9 areas potentially to cover. I won't go through them in detail, but these are just additional questions you can ask. But usually I would look at most of the questions I ask coming from the ASRS. So you've got some confirmation if they've completed the form, but those will give you a very comprehensive range of questions to ask that are accessible, and you don't need to worry about remembering them all. So detection, assessment, you have a fairly good idea that you want to move into a management plan. And as I mentioned before, medication is really the core of treatment. But these other areas are also really important. Education, not only because someone who is well informed is in a much better position to manage and look after their own care, but also because of the process of coming to terms with the presence of this problem. Structure and coping strategies, coaching, and I'm going to say a word about each of these. Coaching, whether it be from a professional coach, but sometimes you can recruit another family member to help with many of the coaching tasks, as long as the relationship is stable enough that the person with ADHD will accept that coming from a partner. Psychotherapy, mostly cognitive behavioral approaches, maintaining self-esteem, and family interventions. But looking at medications, really the basis of approach are the stimulants, and they fall into 2 groups. One are the methylphenidate derivatives. Ritalin is short-acting, and Concerta, Bifentin, Foquest are all longer-acting derivatives of methylphenidate. And then dextroamphetamine. Dexedrine is the short-acting form, and Adderall and Vyvanse are longer-acting forms. But we also still use atomoxetine, which works in a very different way from a stimulant. It's a noradrenaline reuptake inhibitor. We use guanfacine and clonidine, which are alpha adrenergic receptor agonists. And we use antidepressants. Those 3 are the ones that are probably most likely to be effective. As I'll show in a moment, there's no real evidence that SRIs address ADHD, and it would be surprising if they did, but they can improve some of the symptoms because they're improving mood and therefore helping to improve someone's functioning. Sorry, I missed the last point, which is a really important one. 80% of prescriptions for stimulants are written by family physicians. And again, not only are you going to be the first and perhaps the only point of contact, but you really don't need a psychiatric assessment or neuropsychological testing to make a diagnosis of ADHD. Hopefully you'll feel comfortable initiating treatment, and then maybe if someone hasn't responded, then to look at getting some kind of further opinion. Annual Canadian prescriptions for adults. The first study is an ISIS study. 2014, there were 5.8 million prescriptions written, and what was significant is that was 119% more than in 2004. And you can see an enormous variation across the country, and I have no way of explaining that other than perhaps some differences in the way primary care is organized from province to province. A BC study that some of you may have seen came out only about a month ago showed, so the first was the number of prescriptions. This looked at the number of individuals receiving a prescription and found an increase of 17% a year. Was 1 user per 1,000 population of adults in 2004. In 2023, 16 users per 1,000. So really significant increase in the number of prescriptions that are being written, and almost all of these were for stimulants. This chart I'm not going to go through, but I do want to point it out because it's in the handout, and it is worth printing off because it covers a lot of comprehensive information on all of the medications. It's produced by CADDRA, C-A-D-D-R-A, and if you only visit one website, theirs would be the website to visit. Short-acting stimulants, methylphenidate is Ritalin, up to 80 milligrams a day. Dextroamphetamine is Dexedrine, up to 40 milligrams a day. So the dextroamphetamine is twice as potent as the methylphenidate. They last from 2 to 4 hours. You can give them up to 3 times a day, and it can be on a fixed schedule or as needed. Sometimes you'll find people who will just take it when they have a particular task, people who won't take it at weekends or when they're on holidays because they need it primarily for work or school, but you'll find some people who like to take it all the time. It can also be combined with a long-acting. A long-acting may last 8 to 12 hours, but usually shorter rather than longer, which means they take it in the morning, it may wear off 4 or 5 o'clock. They can take, say, 10 milligrams of methylphenidate to help them through the evening if they think it's necessary. But short-acting have greater potential for abuse. It was in primary care that someone first introduced me to their habit of snorting crushed up Ritalin. And think of it with university students as well, particularly those who are coming back for larger and larger prescriptions, because the stimulants are being increasingly used on campuses for students who want that period of increased intense study 2 or 3 days before an exam. Side effects, it can affect sleep. Surprisingly, it has less effect on sleep in adults than it does in children. It can affect appetite, but if it does, and these are applicable to all the stimulants, not just the short-acting. If you notice that someone's appetite is down, there's probably a rebound at the end of the day. So their appetite will be, their eating will be less during the day, but they're much more likely to have a bigger meal at the end of the day. There can be rebound as the medications wear off, which is not an issue with the long-acting, or not nearly the same degree of an issue. There can be restlessness, and just be careful about looking for tics. It can be with all of the methylphenidate derivatives, but particularly with the short-acting. So when you're following up someone who started on a methylphenidate, ask them about whether tics are present. And also, before you start, just make sure you get a history of whether there are tics, because in children, Tourette's is a combination of tics, OCD, ADHD, and temper outbursts. You need 3 out of 4 of those. 90% of children with childhood Tourette's will grow out of it by the time they're adults, but they may still have some residual symptoms as well. The longer-acting stimulants last between 9 and 14 hours. The longest are Foquest and Vyvanse. They tend to have a longer but smoother onset and withdrawal, less potential for abuse, and they have different delivery methods. Almost all of them, except Concerta, can actually be either sprinkled on food or dissolved. Usually more of an issue with children than it is with adults, but again, every now and again, I'll come across an adult who doesn't like taking pills, and this is an easier way to deal with it. And the dosing can be staggered. So if someone is getting benefits from a medication, but finding it wears off at 4 o'clock, so they're taking, say, 60 milligrams of the medication at 8 in the morning, they can still take, say, 40 milligrams at 8 o'clock and take the other 20 at 10 or 11 o'clock. So they're spreading out the effects of the medication. These are the long-acting medications that we currently use. And that just highlights the starting doses. Again, I won't read them line by line, but those are the doses to aim at when you're starting a medication. And those are the maximum doses that we aim for. It doesn't mean we can't go higher, and I will, but probably go higher means 10 to 15% increase in the dose and no higher than that. And if someone is saying, oh, it's great, but I need more, I need more, I need more, then either the drug is not being necessarily used for the purposes it's intended, or I would switch to another medication, because I have seen on a number of occasions really a placebo response. Someone starts the medication, they come back 2 weeks later, great, see them again 3 months, 6 months later, really no difference from baseline. So don't assume just because someone has an early response that that's automatically going to be continued, although mostly it is. In terms of side effects, this medication causes drowsiness and lethargy. Good. We talked about sleep, appetite. The long-acting, less likely to have rebound. Sometimes they can lead to increased arousal, irritability, or restlessness. And again, that's probably a sign to switch to something, to an alternative. Can cause weight loss, not in any significant amount, and it usually rebounds. But you'll sometimes see people who say, yes, I've lost 5 or 10 pounds on this medication, and that's probably worth looking at alternatives. But it's rare that they're used for dieting or abuse to lose weight. But do look at people who do have kind of the paradoxical effect. Well, not so much a paradoxical effect, but an amplified effect. So rather than just calming down emotions, it could actually make them depressed, can make their thoughts foggy, lead to cognitive slowing. They can cause a slight increase in blood pressure and heart rate, but not of stroke or myocardial infarction, and there's no need for an EKG unless there's a pre-existing condition. And if I have someone with a pre-existing condition, I may want to get a cardiologist's opinion opinion from their cardiologist before starting the medication. In terms of the benefits, 1 in 3 do better on methylphenidates, 1 in 3 do better on amphetamines, 1 in 3 will respond equally well to both. 95% of people will respond to stimulants. Probably it goes down to about 70% if you're looking at a significant response. And by significant, I'm referring to how it affects their functioning. Meta-analysis suggests that pound for pound, long-acting are no different from short-acting, but they're much easier to use, they're much better tolerated. Amphetamines may be slightly more effective than methylphenidate, and that's really only 2 or 3 percentage points in head-to-head studies, and stimulants are much more effective than antidepressants. There's some other medication options. Atomoxetine. I've crossed out Strattera, which is the commercial form that started. It's now available in a variety of generic forms. So although Strattera is no longer available and will be discontinued by the end of this year, atomoxetine is still available. It's a noradrenaline reuptake inhibitor. It works more like an antidepressant in that it takes 2 to 3 weeks to work. It was originally developed as an anti-anxiety drug, so it can be helpful in individuals where there's ADHD and either some restlessness, some anxiety symptoms, or maybe difficulty in sleeping. and it is, again, a once-a-day drug, lasts for 24 hours. Monitor for liver damage, and just make sure you monitor for suicidal thoughts. Not a major factor, but again, much more of an issue if you're using it in children than in adults, similar to using SRIs. Guanfacine is, as I mentioned, an alpha adrenergic receptor agonist. It's usually used as an adjunctive medication. It's not necessarily first line, but it can be tried as a first line if someone isn't able to tolerate a stimulant and atomoxetine isn't effective. It can also be used in conjunction with a stimulant and both to get an increased benefit from each, but also because of their adjunctive effects. It's a drug that needs to be swallowed, not crushed, and stopped gradually. And if you're starting someone on guanfacine, start them with 1 milligram a day and gradually increase it, maybe every 4 to 5 days. And you're doing that for two reasons. One is just to make sure you're not seeing any side effects or problems. But the second is you're monitoring they're monitoring improvement by incremental dose increase, because you're still looking for the lowest available dose. And if you go up too quickly, they may be getting the same benefit from 5 milligrams that they would from 1 milligram. Clonidine, also, I mean, it's a drug that's been around as long as any that we use. It still can be an effective drug, not a first line, but can be effective, again, if other options have failed. It can also be used in conjunction with a stimulant that's partly helpful, but not completely. And again, it lasts around the clock. Start with 0.1 milligram, and I would usually go 0.1 milligram a week. There's no need to rush. These are problems that have been there for a long, long time, and going slow but getting it right is probably more helpful in the long run. Terms of antidepressants, bupropion and venlafaxine, because of their dopamine and noradrenergic activities, are helpful, as are TCAs that focus on those receptors as well. And that really is, I think, gives you a wide variety of options. And lastly, I'd just like to run through the skills. What are the other things that you can do? Because as in all situations, medication is helpful, but all of these things can help not only to help the individual deal with their problems, but in some cases, reduce the need for medication. Education about the prevalence, and it can be extremely comforting for someone to know that they're not alone. That maybe 1 in 25 people in their community is living with this same issue. Because remember, self-esteem, isolated, sometimes people feel they're different and that they're the only person who's having to deal with this. Explain to them about family linkage. Make sure they don't blame themselves. It's not anything they're doing. It's an illness that they have lived with in many ways successfully, and what you're trying to do is help them cope even more successfully. Provide them with reading materials and answer any questions they may have. These are in the handout. These are just a few books to recommend, and usually it can be very reassuring for someone and sometimes it's part of coming to terms with the diagnosis. They'll take something away and they'll come back a month later and they'll say, I saw myself on every single page. These are some web resources, again in the handout, and I mentioned Cadra as being the first to look at. These are 2 sites that just have a selection of apps that may be helpful, and each of the apps on each of these pages will address a slightly different issue. Some may be around timekeeping, housekeeping, some may be around cognitive performance. So again, suggest your patient looks at them and sees which one may be helpful. And Attitude is a magazine that comes out every 3 months for people with ADHD that again can be very helpful to read. They have some very good materials there. In terms of structure and executive functions, again, these are fairly straightforward tasks. And the nice thing is they're fairly simple, and the individual has the opportunity to change things in their own life. And in doing so, they get the feeling of taking charge of a problem that up until now may have been out of control. So keep an appointment book, notepads in accessible places, use the cell phone or a dictaphone to write things down, post key messages where they're visible, and don't be embarrassed about asking a friend or family member to remind you of things. These are just some of the coping strategies that are part of the overall management. Routines, reward yourself, ways of reducing stress. Sleep hygiene can be very important, including reducing screen time in the hour or two before someone goes to sleep. Maintaining a sense of humor and using mindfulness techniques. I mentioned coaching, and again, this is practical support. It covers a lot of the things that we've already talked about, but it can be helpful if someone can find a professional coach, and unfortunately, very few mental health services include this as part of the range of services they offer. But it can also be taken on by a family member who can help them with some of these tasks. Psychotherapy, counseling may be for other related issues. CBT, it tends to be the basic approach. This is just one approach sphere. When you're addressing a problem, stop, pull back, evaluate, act, reevaluate. And then family and individual support and maintaining self-esteem. In terms of maintaining self-esteem, really recognize a person's achievements and how well they've done, however far they've got, to deal with a problem that can be so disruptive to so many of their activities. Help them to avoid failures, focus on their strengths, avoid criticism, and give them a sense of empowerment. It's their plan, and you're there to help them and support them and to stick with them as they move forward. And also using some of the examples, the celebrities or other historical figures who've dealt with this and moved forward can also be extremely helpful. And in terms of family interventions, use the family partly with the assessment, partly for support, partly to make sure they also know what's going on, obviously with the agreement and consent of the individual involved. Engage them as a coach, support the family as well as the individual. And sometimes you may find yourself supporting a family member because the individual with ADHD is reluctant to come in and see you. So in summary, it's a common condition, a neurodevelopmental disorder, and again, avoid self-blame, characterized by poor emotional self-regulation, no diagnostic test, doesn't need psychiatry or neuropsych, comprehensive treatment, provide information, stimulants are helpful. And I think for primary care, the essentials, consider cues and possible comorbidities. Come up with some simple questions to ask, including them taking them from the ASRS. Medication, you've got a number of options. Just focus on those that you feel the most comfortable with. There really isn't evidence that we said I should be using this methylphenidate derivative from that. Provide structure and information, see and support the family, and know which resources. Before you see someone, you've got 3 or 4 resources that you can refer someone to, whether they be sites or books. And thank you. I do have to tell you to fill out your forms. And if you have any questions after the presentation, that's where I can be reached. So, any questions?
Hello.
Hi.
I just have a question. I thank you for your presentation first. And I'd like your opinion on overprescription of stimulants. Since you've shown us some statistics that the prescription of stimulants have highly increased in the last years. And in my practice, I see a lot of patients for adult ADD that they come and see me. They're maybe 20 to 30 years old, like they work in construction, they've used cocaine a few times for fun, and they started using cocaine more frequently. They don't tell you at first, but then you hear that they take it every morning, and they like the buzz, and they come to get a prescription. And I'm kind of worried that since we already see that there's a really significant increase in prescription, that is going to get worse. And also with the subjective symptoms of ADD, and you showed us some questionnaires that the cases that they need to check are already darkened. It's a bit worrying to me, and I'd like your opinion on that, please.
Yeah, no, I agree with you completely. It really is a two-edged sword. I think there's no question that stimulants are being prescribed for people who don't have ADHD, either because there hasn't been a full enough assessment of other things that could be going on, but sometimes if you only have a hammer, everything looks like a nail. So whatever it is, here's a quick fix. And I think that really highlights the importance of doing a comprehensive assessment of the ADHD itself. It's always a balancing act. I mean, you know your patients better than anyone else, so all the other factors that may be contributing, you'll be aware of. And I think you'll be looking at it as, is this, a separate problem, or is this part of a number of other issues that maybe are the primary focus and not the ADHD? And I think, again, treatment for ADHD also depends on the extent to which it's interfering with your functioning. And if someone is doing relatively well, even though they have ADHD, you don't need to automatically give them a prescription for medication. And the last point is, if someone is on a medication, reassess it 6 months, 12 months, rather than just renewing automatically, just to make sure they are still benefiting.
I have a patient who has a previous history of cocaine and methamphetamine abuse. She's clean now, and has ADHD. I'm really worried about prescribing these medications. I've started her on Strattera. I've not had a lot of good experiences with it in the past. I don't know what your thoughts are on, you don't want to not treat her, but at the same time, I'm worried about, can I cause a relapse or...
How long has she been clean for?
Less than a year.
Okay. I would still say that's very different from someone who is still using. In those situations, I would never say never, but it would be very, very unlikely that you would want to prescribe a stimulant. Someone who has been clean for a year, I think a lot of it depends on the kind of therapeutic alliance and the relationship that you develop with your patient as you develop the plan. And I think you need to be clear with them about your concerns, and work out together within whatever constraints you want to place on the prescribing as to how you're going to do it. So that may be, if the Strattera isn't helpful, if Intuniv or Clonidine aren't helpful, then just trying small amounts, maybe of a longer-acting stimulant, and going very slowly, and just seeing what the response is. But again, you've kind of worked out in advance what the contract is, and what are not only the parameters, but what are the things that are going to lead you to say, no, wait a minute, we need to take a break for now. So I agree with you, not wanting to deny, but just being careful.
Thank you for all the information. My question is, you did show us the slide with bipolar and ADHD. Most of medications used for bipolar and stimulants have a big drug interaction. So what would you suggest?
But as a as a treatment for bipolar or a treatment for...
So they're diagnosed bipolar and ADHD. So
Yep.
what would you suggest?
as a stimulant.
Yeah.
I would say almost all of these are relatively safe for someone who has bipolar disorder.
But if you look at the drug interactions, they say category D, category C. So I was a bit reluctant to start my bipolar with any
Yeah.
stimulants.
No, I think the key is to make sure that their bipolar disorder is well controlled first, because there is a slight risk that you could actually exacerbate it with a stimulant, or sometimes even uncover it. And I think you need to be aware of that. But personally, I mean, despite what you're saying, I wouldn't have concerns. I mean, there are no specific combinations that I would say couldn't be considered. But I would also use a stimulant in small doses and may want to think about atomoxetine or Intuniv as a first choice. So the nice thing is, in almost every situation, we have options to just going ahead with a stimulant. Great. So, oh, yeah.
Thank you for the presentation. Just have a question about Dr. Russell mentioned in one of his lectures something called sluggish cognitive tempo, which is not, as I understand, in the DSM-5, but it's even in the Attitude magazine. So that does not really respond to stimulants. If we have a patient for which we believed initially that they were ADD, ADHD, and they were not responding to all major therapies, should we reconsider treatment and there's maybe another entity we're dealing with, or is there a reason to suspect there's another neurodevelopmental disorder in this case?
I think it really varies from person to person, but I think it's just one of the things to be thinking about. Is this something that maybe I need to rethink, or is this something where there may be a different treatment approach that could be considered? Also add that in major depression, Ritalin, short-acting methylphenidate, is sometimes used as an adjunctive treatment to an antidepressant, particularly for psychomotor retardation. So I think, again, it's not just following an exact algorithm, but at a number of steps, just making sure, do I need to rethink the diagnosis? This isn't working. Could I try something completely different?
Thank you very much.
Do we know why there's such a link between ADHD and bipolar? Because we saw the link between anxiety and depression, and patients often see that and it helps them understand what bipolar.
Yeah, I think we will when we understand the genome a little bit better. And it's interesting that it is more a one-way relationship than a two-way. You're more likely to have ADHD if you have bipolar than the other way around. I wouldn't even begin to speculate, except to say, there is overlap between symptoms that are along a spectrum. So it may be we're actually thinking about more than one type of ADHD or more than one type of cyclothymia. Same way as we now think about schizoaffective disorder, which is neither schizophrenia or bipolar. And I'm not saying that we should propose that as a theory, but as I just think about why that might be, I think that's what we're going to find. And as we move towards precision treatments, we're going to be able to use the genotype to be able to focus much more accurately on the subtypes of both of those conditions.
Thanks.
So if there are no more questions, thank you very much for your time. And I'm sorry there weren't any questions about Arsenal, but if you want to ask me anything afterwards, I'm happy to spend the next hour or two discussing it.